On-the-scene coverage of ACC 2015 is supported by Effient.
I'm Peter Block in San Diego at ACC 2015 for On the Scene. With me is Mark Sabatine from the Brigham and Women's in Boston, and Mark has reported on the Pegasus trial. So Mark, I'm not going to spend a lot of time talking about data because this is 2 days old already and we're getting tired of hearing data, but give me the short version of the outcome of Pegasus to start.
Sure. We looked at 21,000 patients who had a prior MI 1 to 3 years prior, randomized them to ticagrelor 90 twice a day, 60 twice a day, or placebo. Both ticagrelor doses significantly reduced the risk of cardiovascular death, MI, or stroke. So
ticagrelor is a pretty good drug in addition to aspirin, right?
Right, exactly. All patients were on low-dose aspirin.
Right. So aspirin plus ticagrelor plus equal, or aspirin and ticagrelor, and the combination wins. So having said that, tell me what that really means. Now, we're talking about long-term therapy here, and we're talking about a combination of drugs that actually can increase bleeding. Are there patients that should not have that? Obviously, patients at high risk for bleeding, but tell me what your thoughts are clinically here.
Yeah, in terms of the long term, I think that's an important point. On average, patients were 2 years out from their MI, and we followed them for on average about 3 years. The longest follow-up was just under 4 years. And so by the end of Pegasus-Timi 54, more than a quarter of patients were more than 5 years out from their qualifying MI. So it really is long-term therapy. As we know, ticagrelor looks very good in the acute coronary syndrome setting, but the guidelines currently say we have no data beyond 12 months and we should stop ticagrelor then. Now we have the data to continue. In terms of the net benefit, there was a greater reduction in ischemic events than there was causing bleeding. So you prevent a third more CV deaths, MIs, or strokes than cause TIMI major bleeds. And importantly, there was no difference in the so-called irreversible bleeding. No difference in fatal bleeds, no difference in intracranial hemorrhage.
Well, that of course is good news, and that makes it a little easier to make that clinical decision because the pluses are greater than the minuses in that one. But there is, of course, that other issue, and that is the unfortunate issue of cost. So ticagrelor is going to be more expensive than clopidogrel. So given the option, we don't have any trials that are going to have clopidogrel against ticagrelor. It's probably never going to happen. So what's the thought on that one?
Yeah, well, I would say the doses of ticagrelor we gave, even the 60 milligram dose, achieves more inhibition than clopidogrel 75. So I would follow the evidence base. For my patients, when they come in with an ACS, I treat them with aspirin and ticagrelor for the first 12 months, and now on the basis of Pegasus-Timi 54, I would continue the ticagrelor because that's the prospective evidence we have.
So you're one of these hard-knock guys that wants to have data in order to be sure that you do the right thing for the patients, but you don't have any data about clopidogrel, to be honest, do you?
That's right. That's why I'd follow the database. Yep.
Okay. So there you have it, folks. For those, again, out there in the trenches taking care of patients that have had myocardial infarction, ticagrelor looks like a good bet with aspirin, combination therapy, at least 2 years. Now we have data to support that. And if you're a hardcore data person, that's the drug to choose. Otherwise, we still have to wait and see. I don't think we'll ever get a trial to compare the two, but we'll see how it all comes out. But ticagrelor is a winner for now. Thanks, Mark.
All right, thanks.